So basically, this is the study I want to share with you, the GUD for reduce for distal hypospadias. Besides, it's the result of a prospective photo-documented study. So we have access and documentation of all operations performed. As you are aware, there are multiple procedures in hypospadias. The Snodgrass or the T procedure is the most done, but there are some alternatives. And we are now proposing the GUD technique, which we have previously reported in a video and also in data showing our preliminary results. We were able to report on 164 patients with distal hypospadias and with a follow-up preliminary of 21 months, in which, as you notice here already in this first series, we had 17% of cases which were redo, mostly patients where there were glans dehiscences or the very common coronal fistula after other repairs, inclusively the tip repair. It's something that we see very frequently in our experience. Besides, this technique has been also reported in the Hadidi textbook of pediatric urology. As you see here, all the procedures, they divide the glands in three parts: a central plate and two wings. These wings can be mobilized, but as you notice here, they are minor tissue. They are not so generous because a considerable part of the glands is being used for the central plate. And we are proposing something totally different. Instead of opening the glands in three parts, we open in two parts. We circumscribed here the meatus here, and we will open generals the glands like a book. And then this is the procedure. You will incorporate two principles: the mobilization, which is minor, as you see here, not more than 1.5 centimeters, but you can move it cranially. And as far as you open the glands in two parts, exactly in the middle, you have very generous tissue to refurbish the glands and the organization. And this is interesting because there is evidence that already the complication rate is related to the glans width. Every time you have a glans less than 40 millimeters, these are data from Snodgrass himself, the complications is much higher. And we decided, after gaining experience with the GUD technique, to have more data and prospectively recorded. So we started a database in June 21. The study was registered in our ethical committee and also in the Brazilian Council of Research. And so we recorded the format of the glands, the grade of curvature, the spongious defect, the glans width. We made photo documentation pre and intraoperative and post-operative with a follow-up proposal of 1 week, 1 month, 6 months, and then yearly. So all the data that we have is presented in this way, in which you have information of the case, but also a lot of images to be reassessed, but they were collected prospectively. And it's very interesting, as we demonstrate here in this slide. When we started, it is for primer and reduce in the same time. It's a quick procedure. When you do the inverted wide glans incision, you have a very aggressive opening that you can disassemble, mobilize it, and fixate it, and then you can do the glans reconstruction. You simply put a Tegaderm dressing and use double diapers. We ask mothers and parents not to bath the child for 4 days, and we leave for patient's comfort stand for 7 days. And then you see here cases of redos that were presenting to us. You see, you have some scar here. The urethra is in the glands. In the coronal area, we just open the glands very aggressively, mobilize it, and that's the end result. Slit-like meatus at the tip with a very nice result. Here, in other cases, this patient particularly has been operated 4 times until we came and did the procedure to get this very nice result. This case is very impressive, a lot of scar and a fistula. So we simply mobilize, open the glands and mobilize cranially the urethra and then reconstructed the glands. We had such a very nice effect like this. Other cases, also with some degree of curvature that were not assessed in the first setting, and that you have those nice results. That's the way you use the Tegaderm. It's simply dressing. We always try to keep the urethral catheter somehow fixed in the abdominal wall. And then here again, which is a very common case in our experience, a previous operated after a T procedure, we're just discontracting and repositioning the urethra after doing the glands operation. We have several cases like this, as you see here, another coronal fistula, glands reconstruction in a very nice post-operative after 1 year of post-operative time. It's nice to see that our fellows are also reproducing this procedure. This is Dr. Rafael Jordan, who is at the time in Ciudad del Mexico, who is also conducting a large series, and these are our data. We have 51 cases, photo documented and prospective. 17% of those were reduced. We had just 1 case of complication, which was a reassessment of a fistula, probably due to this rupture of the urethra. So we have, with this still short follow-up, but prospective of 16 months, the conclusion that GUD is good, simple, and reproducible. Thank you very much for your attention, and I hope you can get some interest on this technique and maybe starting in the future to do it as well. Thank you very much.